stand for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. And Dr. Smith, would you mind reading our invitation?
Bow deeply. Dear Father, we thank you for this time that we got to come together and talk about the health of the county and various other issues. And I want to just pray you direct everything that's said and done here and help us to make good decisions on any decisions that need to be made and guide and direct everything we pray. In Jesus' name we pray. Amen.
And next we have the approval of the minutes. You will take a look at the minutes all the way back from May. So I guess we don't have to do that. So we'll just, since we have to have 7 for quorum, so we're actually going to hold off on these votes to approve those minutes. Unless 2 come in. But we'll hold off until next month for that. It was only 1 quorum. Okay. How do we do the agenda for approval? You just want to keep rolling? Yeah, okay. So since we don't have quorum, we will not be able to vote on anything. We'll still receive information and discuss. So we'll move into old business. And then Janet, if you want to take that one.
Thank you very much. So, at our last meeting, which actually was in May, because we did not have a June or July meeting, due to normal schedule and then conflicts from a scheduling perspective, we discussed the application for the social worker position, which is Ms. Kirsten Abraham. And at that time, the request was made to be able to hold on voting and take a look into the candidate. And so I know obviously we can't vote at this point, but we have reaffirmed Ms. Abraham's interest. And so if we get a quorum this evening, then you all could come back to this and take action at that point. But if there's any discussion that y'all would like to have about the candidate, you can have discussion now if that's something that you want to do. And if we don't have a quorum, then we'll bring this back at the next meeting.
And I was just going to ask if anyone knew the applicant applying. All right, and then I think it might be a good idea if we choose to interview her before the next meeting. If you're I think that's a good idea. Yeah, I think that's good. And obviously we'll hold off until the next meeting. We cannot make a decision, and hopefully be able to get an interview in. And would any of y'all be interested in helping out interview her? If we get maybe, I know I can, if maybe 2 others would mind helping interview, so we can arrange a time. I can probably help you go to Zoom. A Zoom online? Okay.
If you guys need any help with that, let us know. We'll be happy to help set up the Zoom. And if not, we'll bring it back on the agenda for next month.
Thank you, Janet. All right. Thank you. So we'll go ahead and move into the division report to receive information on the 2022 communicable disease statistics. Thank you. So this annual report will be presenting the 2022 statistics for the communicable disease program. We'll be reviewing disease statistics, communicable disease outbreak and cluster information, STI review and alert, and CD program efforts. As you hear, our enteric and food and waterborne disease statistics, obviously there were some notable increases in case rates, significantly for Salmonella and Campylobacter. It could be due to many changes, source exposure and spread, changes in the affected population, differences in the pathogen itself. It's thought to be also contributing factors that include increased travel, increased activity within the population as compared to previous years, which could be contributed to COVID. Any questions?
The Salmonella, I mean, that's in Campylobacter, that's quite an increase over the years prior to COVID. I noticed that seems to be when it really got bad. I mean, how much do you think it's got to do with people maybe, I mean, they weren't traveling as much in 21, I wouldn't think.
Right.
But maybe home more and.
Exactly. It's thought, with the past year, even in 2022, there was a significant increase in movement, travel, international travel as compared to years prior, just with that opening, and then also.
Can you go back to that?
Yeah. And then obviously with the 5-year average, those COVID years would impact that.
In 2021, we also started including PCR testing, where prior to it had to meet confirmed criteria and it had to be a culture. But we treat the cases that are probable with a PCR test positive the exact same way. And so it was decided that we really should include those in the numbers of cases that we're seeing. So that's where we jumped, from 2020 to 21. That plus, maybe some more movement than we had in 2020. So we're still, 80 cases as opposed to 60s.
Another thought, it might be increased desire for testing. Prior to COVID, people probably were more likely to just ignore symptoms and wait it out a little bit, longer. And being that's diarrhea is one of the symptoms sometimes of that, it might just be more testing and not really a higher rate because of the testing.
And one thing to note is we really did not find any significant epidemiological links to any cases. So there weren't any identified like clusters or outbreaks for that. So for vaccine preventables, there was, and you can see the noted increase in influenza deaths. We'll talk a little bit more about the 2022 to 2023 flu season. It was significantly impactful and resulted in these increased deaths. Otherwise, the infections themselves were kind of comparable to previous years and years prior to COVID. Yes.
The whooping cough incidents, were they breakthrough from having a vaccine, or were they unvaccinated?
Can't give those specifics. To do that, we would have to look at each individual case, and I can do that and possibly help clear that up.
Excuse me, do we have a breakdown of the deaths like we was before we had by demographics?
I don't have it in this report. There are some breakdowns of demographics for the flu season itself, but not specifically for Union County. So for immunization review, we participate in benchmark assessments that occur every October. This is where the state will run assessments at specific age ranges to ensure they're up to date with childhood vaccines. The age groups include 36 to 72 months of age, 24 to 35 months of age, 12 to 23 months of age, and then less than 12 months of age at time of evaluation. This report tells the number of records analyzed and how many of those records show up-to-date vaccines or any vaccines that were received late. There's no analysis of, or on this report, there's no analysis of county residents who do not have immunization records for North Carolina. So it is based on NCIR records. For Union County department clients, we are at 100% success rate for meeting the benchmark, meaning all of those clients that we see in those age ranges were up to date on their vaccines. For county residents, it was 72%. Our goal, so our goals increase for the county department. They will increase based on what our previous year's assessment was. Our goal for this, for the 2022-2023 year was 90%, and so we exceeded that statewide averages, and this is compared to other health departments, and it was 77%, and then for county residents as a whole, as compared to other counties, we were at 76% as compared to 71%.
How's the county number doing, that 76% number compared to previous years?
It's, so we held at 72, it was the same last year. I would have to look back at previous years to determine exactly, but typically that's around the percentage that we
I'm just kind of curious about, you know, post-COVID with a lot of the vaccine hesitancy. I seem to have seen a little bit more of that in the patients that I'm seeing, and it's not a substantial amount, but more than I did see. I'm just wondering how that's going to impact the county in the long haul, you know, down the road.
Yeah, I think, don't mean to butt in, but I think that is a, you know, obviously a question. A lot of counties, I hear from other colleagues across the state that, you know, there is concern about countywide or statewide, you know, meeting goal for a lot of these because there is some concern that there may be some reluctance. So it's a little bit, I think, premature. It'll be interesting to see what happens next year. Quite honestly, the fact that it's 72%, it's about what it was the previous time. If you go back even further, I mean, we've typically been in the low 70s. So, you know, does it go down or does it stay basically the same will be kind of an interesting take moving forward. But yeah, that is a good point. It's a good question that we'll keep monitoring. I mean, one of the good things is, you know, at least from the patients that we serve, you know, we've maintained a very high meeting that benchmark. So we're pleased with that. I mean, that's obviously one of the things that we can't do. We can't control what happens in other, you know, pediatric practices or other locations. We just try to support those groups and encourage them in the process.
In fact, this was a national story on NPR this afternoon about vaccine hesitancy post-COVID, parents experiencing and also objecting to commonly administered vaccines.
Are there any demographic breakdowns on that, on what that 72 to 76% looks like?
I think so.
Information about the 2022-2023 flu season. It was characterized by, it was kind of an earlier onset. We saw a really high peak earlier on as compared to some of the seasons previously, and increased mortality. We had 6 deaths just in Union County, whereas As compared to 2021 data, there were 7 total deaths in North Carolina as a whole. As compared to statewide for the 2022 season, there was 196 deaths across the state. As characterized here, there was, most of them were adult deaths, 193, 3 pediatric deaths, and then the demographic age breakdown for those deaths. Majority of the cases subtypes were influenza A-H3 and influenza A, 2009 H1N1 subtype. It saw also that this increase in respiratory illnesses, flu and otherwise, also contributed to increases in invasive group A strep cases, which I'll discuss a little bit later. And there was also shown to have increases in human metapneumovirus, a viral infection similar to a cold that's in the family of RSV. And that kind of occurred around the same time as the flu spike. There was also followed by an increase in RSV. Despite the overwhelming spike from the Omicron variant, there were fewer cases reported within NC COVID surveillance system. This is thought to be due to expanded availability of home testing, and these results were rarely reported. Of note, we're currently participating in an Atrium pilot program called USAVE. It helps provide targeted outreach using metrics in wastewater surveillance system. Genotyping is also done with the wastewater surveillance, and this helps identify the most prevalent circulating variants. We actually have 2 sites in Union County for wastewater surveillance.
What was the name of that program?
USAFE. So for COVID vaccination, here is the data for that. In 2022, our division transitioned from CDNS, which is the original program used to document and track vaccination. We transitioned to NCIR, which is the immunization registry, and this was at the recommendation of the state. This kind of made it a little more difficult to pull out specific administration metrics for us as a division for our Department of Home, and also for demographics. So this information was pulled from the state dashboard. Also changes in vaccination for COVID-19. The Janssen vaccine has been discontinued, and then the bivalent vaccines were introduced for ages 5 and older.
That's a question real quick.
Yeah.
Maybe Dennis could elaborate on it. You talk about the wastewater surveillance. How pinpoint accurate is that? And how do you, they have certain locations, and maybe can you elaborate on that a little bit? How they do the testing and how accurate it is per location? Like I say, this group comes because of our wastewater calculations here. How do they do that?
Well, it's extremely accurate in terms of identifying COVID, for example, in wastewater. It's basically, there's a process. We work very closely with UNCC. UNCC started in North Carolina, became one of the leading academic institutions to do wastewater testing. And in fact, the state has relied on them to also provide a lot of the assay development that is necessary to do the testing. And while there's other places in North Carolina, I know the state, not the state, but I think UNC and maybe ECU, there's a couple other academic centers that are doing testing across North Carolina, but as we moved away from case finding, case numbers that we've been counting all these years, really the only two ways we can monitor the severity of the virus in the community is to go through wastewater surveillance and hospitalizations, if it gets to that point where you're actually having folks admitted. So those are really our two surveillance metrics that we're looking at now. In terms of the wastewater surveillance, they take a once a week, they pick two samples up from sites. They're collected. There's a protocol that they're collected in, and they are taken back to, in this case, UNCC, and they do the testing there at their laboratories. And then they work in concert with the state to communicate the data for these particular sites that they're doing the testing of. That same thing is occurring in other places across North Carolina, depending on which location is doing the sampling and testing. It's kind of an up-and-coming way to look at public health disease surveillance. Many of you may be familiar back a little over a year ago when there was the polio case in New York City, or New York, I don't think it was New York City. It was, that case was identified, and the very first thing everybody was asking was, well, if it's one case, that means there's probably more. Well, how do you know that? Because it's not like they're just presenting to a hospital or whatever at that particular time. They did some wastewater surveillance with an assay to look at picking up the polio virus, and they were able to determine that in the community area where that person was, there was other positive virus in that community. So that is, you can't pinpoint who or where. I mean, it's very nondescript in that regard, but it does give us an indication if we're seeing trends that are increasing or decreasing, and it can tell you somewhat of the magnitude of the problem. And then from that standpoint, you know, you could use that for messaging. For example, recently over the last several weeks, probably last month, the wastewater surveillance trends in North Carolina overall have been increasing. And that is also being played out a little bit with hospitalization data, showing that cases have been increasing some. Now, it's nowhere near where it was back during the Omicron rise that we saw. It's still relatively low, but it's sensitive enough that we're able to see that, yes, at least for right now, over the last several weeks, there has been a little increase in COVID in our communities. Interestingly, and this is totally somewhat anecdotal, but it's not uncommon. I've even heard folks talking about it, whether you're at friends or at church or somewhere else. You're hearing other people talk about, oh, well, it's interesting. I'm hearing people are testing positive for COVID. Well, it's really been out there. So we have seen that little bit of an increase. So I digress a little bit there, but it is very sensitive in terms of being able to pick up, and it can actually pick up the different variants of the virus. So they're able to tell, all right, well, which subvariants are they? Where are those mutations occurring? Where is the variants occurring in different communities where the wastewater is being tested? So does that help?
Thank you more than what I need.
You got me on a roll.
Thank you, Dennis.
It really is interesting, because even with the polio cases, like, those cases were asymptomatic, and so you could see those trends, and whereas they weren't otherwise identified.
Is that still published data? I mean, this is of interest to me. Like my mom and dad have had polio this month. my boss has it currently. COVID.
But
Yeah. And it's in my son's, workplace here in Union County. So, I mean, so I'm seeing it on the rise.
Yeah.
But I mean, do we know anything about those variants that are on the rise and what they look like in comparison to the past two, right?
Yeah, I don't know which ones they are.
So EG.5 was the most recent that's on the rise. It's still, the most dominant ones are going to be XBB.1.5 or .6, whichever. It's still of the Omicron family, but in our most recent calls, it's the EG.5 that's kind of like they're noticing it's picking up momentum. But it's still going to be those XBB variants, and that is one of that's the sublineage that they are recommending the seasonal vaccine be based on.
And the good thing is, all of the new variants that they've seen so far that are progressing continue to not appear to be overly aggressive in terms of severity and hospitalizations and that kind of thing. Obviously, with anything, folks who have more compromised health conditions would be at a little greater risk for anything. But, that's one of the important things we're looking at too, to see if you have all of a sudden increased hospitalizations that are occurring where you might get a little more robust variant, and we've not seen that yet. Hopefully we won't.
Here's the data for direct contact and respiratory illnesses. As we mentioned, there was, and you can kind of see it here, but in 19 and 20, we had, pretty significant increase in the invasive group A strep cases. It's kind of, tapered out in 21. Well, in 22, we saw an increase, and it's kind of thought by the state and nationally, epidemiologists to be accredited to the respiratory or flu-like illnesses, increase in respiratory illnesses. So it was really interesting to read those reports.
You mean they're just swabbing more?
Yeah.
Well, increase in hospitalizations, and, otherwise identified because, group A strep can cause non-invasive infections like pharyngitis, scarlet fever, and impetigo, but it's when you have it kind of gets into other parts of the body that's not usually found, like deep tissues, muscles, blood, and lungs, and that's where they kind of put that link together because a lot of it was respiratory infection.
Another thing to think about is, the fact that with COVID, a lot of the most vulnerable people, wouldn't be here. So, you would normally expect to see infections really going down at this point. And so that's kind of concerning to me to see some of the numbers either at average or higher.
And that was one of the reasons that it was kind of thought to be related to that significantly impactful flu season, just because they kind of correlated those infections around the same time as that flu spike. And so that's why it was thought to be linked. So for 2022, we had 3 active TB cases. We administered for TB TSTs and IGRIS, which is the blood testing. We did 451 high risk and 205 low risk. That was, a lot of it was the refugee parolee clients accounted for 202 of the tests. All of those would have been high risk. There were continuous medication shortages for most TB medications, which impacted the initiation of LTBI treatment. We had a total of 119 LTBI cases evaluated, 29 treatments initiated, 13 completed. and then 3 of those treatments rolled over into 2023. Of note, we currently have 3 active cases so far for this year. There are 6 in LTBI treatment and 14 on the waiting list. And, you know, those medication shortages continue to impact those that are waiting for LTBI treatments. We do prioritize high-risk cases for LTBI treatment, such as those with immunodeficiency. And for vector-borne and zoonotics, had some increases in most all metrics, so marginal. For the rabies, all animals identified were skunked. We did do an outreach to remind residents, or outreaches, we continue to do outreaches to avoid feeding wild animals, to keep rabies vaccines for pets current. We also collaborated with Dr. Broadway, our county veteran, for an outreach event. We identified high-risk residents, such as farmers, rescue employees, to offer a complete series of rabies pre-exposure vaccine series. A lot of the, that population is not covered by employers, and it's a significant financial impact for that high-risk clientele. We have had no pneumococcal meningitis, and that's pretty consistent with years past. There was a significant increase in NTROs, and it's a commonly acquired infection. So again, it could be a correlation with increased hospitalizations. So for outbreaks in clusters, the outbreaks included outbreaks of influenza and invasive group A strep within long-term care centers. COVID outbreaks occurred in a variety of congregate care settings, such as long-term care, residential care facilities, detention facilities, and shelters. All clusters were identified in school or child care settings. STI infections continue to be on the rise, with some conditions doubling the 5-year average. Some of it can be attributed to increased screening, most notably for hepatitis B and hepatitis C. But, a lot of like gonorrhea and chlamydia, that's going to be also due to a reflection of true increase in occurrence of infection. Also, the occurrence of early syphilis is more than double the 5-year average, which is really concerning. So early syphilis, it's defined by stages. So early syphilis is if an infection can be identified, like if somebody has had a negative within the past year, and they are identified to be positive, that's an early infection, and then if they present with symptoms. So you also, like late latent syphilis would be if there is an unknown duration of infection, or if it's more than a year, identified as more than a year. Yeah.
It's concerning because of the risk for congenital syphilis. There's, completely treatable, but in community counties not had any congenital syphilis cases, but we are seeing them. In North Carolina, we have here at our health department, the late-term pregnancy found a positive syphilis case that had been negative when she was first tested at the onset of the prenatal care. So it is definitely something that
providers need to be aware of and keep their eyes open for. Along with the increase in syphilis is a shortage of LA bacillin, the best treatment for it. So we have a contingency plan when our stock of LA bacillin is 2 weeks or less to be able to treat the number of cases that we typically see. Then we use a second-line antibiotic to treat people who are not pregnant for syphilis and reserve that LA bacillin for pregnant women so that they can be treated with that until we're able to get more stock of the bacillin in to be able to treat everybody with it.
And we also have, stepped up the recommendations to, just be diligent in that testing during pregnancy, just to identify any of those late-term infections to ensure they're promptly treated. Yes, that did matter. Also in 2022, we were met with the Mpox response. It's a viral infection spread from person to person or between people and certain animals, causes rash, flu-like symptoms, fever, respiratory symptoms. And so we responded with testing, vaccination, outreach, and education. We had 4 positives identified in Union County, all men. One of those cases were reportedly had no known exposures. So no epidemiology links for one case. The other 3 did have identified known exposures.
Are there any commonalities demonstrated among the cases? I mean, that's a substantial rise in cases.
All of those cases were, for Mpox or syphilis.
Is there any common factor that would explain why it's such a, that's double the 5-year average?
I mean, there is concern for, a true reflection of increase in infections, increase in incidence.
Resistant to what?
Like, it's a reflection of increase in infections. It's just spreading.
As a whole, you mean?
Yes,
Nationwide.
yeah.
Yeah, I mean, the trend, one thing to keep in mind here, it is alarming, 54, I mean, of all the figures you're gonna see on this, the most, from a public health standpoint, there's a lot of important information, but the syphilis data is one of the most concerning of it because it's demonstrating that we're also following the trend that's being seen nationally and statewide, that the increase in syphilis is really there. And, it goes to the, behavior and activity and early treatment and early identification is so critical in this process. But that can be said for most other STIs too, in that regard. And I don't know that I'm answering your question on that, but I do think that it's, it's related to once you get core transmitters in a community, it will spread, and we're seeing that.
Well, is it being studied in the county to look into the history of those that have it more, where it is spreading more, to try to identify behavioral commonalities there?
Demographics and risk behaviors. Yeah, and that's something that's occurring statewide, nationwide.
Right. Mecklenburg has had huge increases and have been doing a lot of work with tracing back to, where those first infections are occurring and addressing them.
And so with each of these positive cases, a disease interventionist reaches out to them, does contact tracing, ensures that each of their exposures are tested and treated appropriately.
Is there any type of educational
Targeted
efforts
outreach.
that are to target what the problem is and then try to address it? And
Or, I mean,
When we have, you know, directives from the state that say, you know, providers, please keep this on your radar, keep, you know, testing for this, that's disseminated through the medical provider list that we have to remind them to, you know, have, when they see a rash, to have syphilis in their differential diagnoses. You know, we do a lot of education here in our clinic. When we're able to go out to health fairs, you know, definitely STD testing is something that we're thinking about. We are currently offering rapid HIV testing, and our lab manager is working on syphilis and Hep C testing to be able to run rapid. And I think that we'll identify more cases, you know, once we're able to do that as well.
Seems like they should have something like a, possibly some, maybe Mecklenburg, this whole area, if there's such an increase, something like some public service announcements. I mean, it's good for the medical community to know and react, but what's going out to educate maybe the populations that this type of stuff is on the rise in the communities?
right, and that's definitely, you know, education that we provide when we have clients present, and we, you know, try to disseminate that to our provider list. Another thing our lab director is working on is getting testing, bringing it back in-house, which will more quickly identify those positives, and we can treat them at time of visit. You know, it is concerning that, so Biocelin only has one manufacturer, so depending on how long the shortage lasts, it could impact those treatments, potentially. You know, although we have the alternative treatments, at what point are those supplies also impacted? So, for disease program efforts, we've continued to work on role development for teammates. We've established a school and daycare liaison, a long-term care liaison, and we've added depth to our TV program with a formal backup. This just provides those facilities with consistent point of contact so they know who to reach out to and can provide consistent guidance. We increased response with the U for You initiative, and also added depth to our refugee health program as far as staffing. Outreach events included hepatitis B, flu, and COVID vaccinations at the Union County Jail and community shelter, Mpox vaccines at community events, targeted outreach for those events, vaccine lookup for multiple community events. We've also continued that through this year. So those back to school events, we go to ensure we look up vaccine records for parents just to be proactive in getting those vaccines done in time. Rabies prep for the high-risk Union County residents. Expanded STD testing and uninsured males. So some of the funding was used to provide gonorrhea and chlamydia and trichomonas testing, whereas previously only part of that testing was provided by the state. So we were able to expand that. CCTC collaboration, they helped us screen positive patients to identify high social vulnerability, you know, just making sure they had appropriate supplies, food security, so that they were able to appropriately isolate and quarantine. Outreach to long-term care and assisted living facilities. We assisted with provider enrollment so they were able to administer their own vaccines, document those vaccines, and keep track of any needs for COVID vaccination. We also collaborated with NCDHHS to pilot a program for specimen submission to the state lab. So now any GI outbreaks, just to ensure the state lab receives samples and can appropriately subtype those samples And then also continued collaboration with UCPS to identify positive students and contacts and help provide that guidance there. So with the Omicron peak, we continued our response and offering vaccines. With high pathogen avian influenza, we perform risk assessments and monitoring to quickly identify any needs for testing or anything for those that are very exposed. We have no identified positives or those that are symptomatic for any exposures.
Does any part of the disease efforts involve efforts to try to help modify behavior?
I mean, a lot of it, so a lot of what we do is provide education to local providers. We send out any health alerts, and that indicates, increased need for screening, what to look for. We did do, like with the targeted community events, just letting know, hey, you could be at risk, providing intervention, and again, that risk notifications.
And I would agree that I think, education's a key piece. I think it would also be, I'd be remiss to not say some of the work in the schools is also very important in terms of education around some of the risk factors that are occurring, because that's a critical piece as well. So yes, there's a lot to go around in terms of educational need. Picking the locations and the best way and venue to communicate that is always challenging, because there's always sometimes resistance on some of the messaging that we're providing or could provide. And so we have to work within those parameters in our community. So, but the community support and outreach, the health promotion staff that Stephanie has are certainly open, and we try to avail ourselves to educational initiatives, but from an educational standpoint, the gives the greatest, the squeeze gives the greatest juice, I guess, when you're able to identify target groups, target messengers to convey that information to the right populations. And that takes a lot of work and a lot of energy, and I know staff are open to that. So I don't mean to belabor that, but it's a key thing, but there's also sometimes limitations to the effort as well.
I think we do a great job with our, hand washing, food storage, cover your cough. We have lots of venues where we're able to get that information out with environmental health and child care centers and schools. Getting education out about STI prevention is much more challenging.
I have a concern that during a lot of public educated students learn about sexual health through their health class in school. And during COVID, online education was less than effective at most things, and probably even more so at sexual health. So there's kind of a gap in there of 1 or 2 years worth of students that totally missed this education through the public school system, that I don't know when they'll catch up or where they'll catch up if it's not taken on by the family.
I think it's a valid concern.
Yeah.
I think you're right.
A lot of the public, I think, in the culture that we live in now, is just too afraid to address these topics like it really should be. If we had forest fires continuing to be lit in different parts of the community, certainly there would be educational campaigns to, well, you might want to reconsider getting out and striking matches. We have no burn seasons, when things get out of hand and there's a risk of fires going on. And I think people need to be willing again to talk about the fact that, I mean, promiscuity is not a good behavior to have. It's something that should be discouraged, and traditional family structure is something to be encouraged. People are not willing to say that. I am. I think it's very important. If some of the educational efforts would center on trying to help people to understand the benefits to monogamous relationships again, and having stability of family, and doing things in the county that would encourage traditional, strong families again, we would see these kind of numbers decrease. There's no doubt about that in my mind. It's just whether people are willing to speak the truth about it. Or we'll continue to see it worsen.
Thank you. Thank you, ladies. So next, we did have the health clinical service fees. Is there anything to present on that, or is that just today?
We can discuss the fees. There actually are going to be two. Well, there's one and then tobacco and then another. Sorry. But I think it probably, since we can't take a vote on it, probably makes sense to not discuss this one because that one isn't urgent. It is important. When we get to the second one, I think we may want to at least share that with you. And while you cannot take action, that is more time sensitive in nature. And so we will take it forward. Well, we'll address the next one when we get to the next one.
Sounds good. So we will move into the tobacco-free campus policy.
This information actually is, it was a holder. This was put back in our system back in May, and the information on here is a little now outdated, so I'll update you on this. As part of some of the Medicaid transformation requirements, as we've shared before, one of the things that's going to be required for receiving Medicaid dollars is a tobacco-free campus policy. We plan to present that information. Initially, we thought this was going to have to be in effect April 1st of 2023. That was extended to go into effect April 1st, 2024. So we plan to take this policy for the Human Services Campus tobacco-free policy to the commissioners in September to make them aware of that, and then we'll be implementing that shortly thereafter. But we do now have a deadline of April 1st, 2024. So
Yeah. Any questions about that one?
That's good.
It is good. Some forward progress is forward progress.
All right, so we'll receive information from the Public Health Breast and Cancer and Cervical Cancer Control Program.
Clock goes back.
Oh, side
Bad button, okay.
error.
Okay.
My name is Emily Irvin. I'm the BSEP coordinator for Union County Health Department. And I've really taken on since I've taken over in January. A lot of people say BSEP and they don't know what it means. It's the Breast and Cervical Cancer Control Program. It's a statewide and federally funded initiative. Each county has funds that they get every year. And I'm just going to talk to y'all about what this program is and how it can help the people of Union County. So the North Carolina Breast and Cervical Cancer Control Program provides breast and cervical cancer screening to the women of actually Union and Anson County. Anson County does not have the program. So we kind of take over those targets that the state gives us. And this is for low-income families. For the screening, we do women over 40 to age 75 for mammograms, and cervical cancer screening, we do 21 and up. But anybody who has a current problem, we can see in the VSEP program. We've been working very closely with our family planning program to look at funds and see how to best serve each client. So with this program, we can pay for pap smears, mammograms, clinical breast exams, and we do the clinical breast exams and the pap smears here at the health department. We currently send out our colposcopies, but we do cover those services. Most of our patients that get their colposcopies either go to a local provider, Union OB, or there's a low-cost clinic in Cabarrus County we send our patients to. That can be much more cost-effective if they don't qualify for this program. But we try to give as much screening for cancer as we can. The state and federal government gives us a different target every year. Last year our target was 50. We actually went over by 1, but we had some extra funding with our BCCM that we didn't use, which is the Breast and Cervical Cancer Medicaid this program also works with. So we were able to cover that 1 extra that we saw. This year our current numbers for targets are 65. So that rounds out to about 5-ish a month that we can see and get screened for services that they fall through the cracks and normally wouldn't have those services. A big thing that people think is BSEP is just for little old ladies, and it's not. BSEP program, like I said, anybody with a permanent form of birth control, like a tubal ligation, a hysterectomy, they don't meet family planning services for pap smears and clinical breast exams, so they meet the BSEP requirements. Like I was saying before, to be eligible, you need to be in between the ages of 21 and 75. Some of our services that can be covered by Family Planning Clinic, they are seen there, but then they may fall into coverage for BSEP to pay for the other part of their screening. Like if they're a 40-year-old woman who needs a mammogram and a pap smear, but she's still considered to be fertile, so she would get her pap smear and a clinical breast exam and family planning, and then would also be a BSEP patient, and we would cover her mammogram. And like I was saying before, BSEP is considered the payer of last resort. Talking about the targets I was talking about earlier, each target is funding for a patient. We receive funding from our funds for $325 for each patient we see. Some patients only need a mammogram. Some patients need a mammogram, a diagnostic mammogram, all the way to a biopsy, and we can pay up to even the consult with the surgeon if it's needed. So depending on what each patient needs, those funds cover services. And like I said, if one patient only needs one thing, the rest of the money is used for a different patient. And every patient we have has a risk assessment done. So some women who aren't age 40, maybe because of family history or their history of different demographics, they may qualify for more screening that they wouldn't necessarily qualify for if they hadn't had that screening with us. And we also identify barriers. A lot of our patients don't know how the system works. They don't know when they're asked if they have health insurance, which our patients don't, but there are other options for them to get those health screenings. Transportation is a big thing. Getting them signed up with the Union County Transportation is a great thing for our patients. And a lot of them, it's just confusing. I give out my direct number because even with the information that Charlotte Radiology has with this program, we have patients that go up and they are confused and they ask about insurance, and the patient's scared to get the testing because they're scared that they're going to have this great big bill, but it is covered by us. So breast and cervical cancer Medicaid is the other part of the program that I do. So anybody who's diagnosed with breast cancer or cervical cancer in Union County can come and see if they qualify. They do have to be 250% below federal poverty level. And with our BSEP program, we've actually cut out the financial part. We just have to have verbal of what their finances are. It was a big issue with different people in the family working back and forth and getting some of that information. So we have been able to take that piece out of it, but for the Medicaid portion, they do have to bring in those hard documents of their financial household. Patients within the BSEP program, they kind of already get walked through the navigation process to get those breast and cervical Medicaid services. But with the patients outside of the health department, any physician can refer anybody who's diagnosed with breast cancer, and we can see if they qualify. But it has to be within the first 3 months of being diagnosed with breast or cervical cancer. The patient themselves can come up and refer themselves. And for each of those patients, our current target is $7 a year, and we get $50 just walking them through that process and getting them signed up for that breast and cervical cancer Medicaid and on the right track to being able to afford the treatment for the cancer that they're diagnosed with. So that was just a little overview and to make sure everybody's aware of the program, because like I said, it kind of falls through the crack and everybody thinks it's just for, you know, the 70-year-old little lady. So any questions?
Any numbers on like cervical cancer cases?
So we see a lot of colposcopies here at the health department that we have to send out for. At least what I'm seeing here in the health department between our maternity, family planning, and BSEP program, we're sending somewhere between 8 and 10 a month out for colposcopies just here at the health department. I don't have exact numbers, but most recently in the last month, I've had 2 to 3 that had to go for LEAP procedures due to CN2 or greater. And anybody who has CN2 or greater can apply for that BCCM coverage for breast and cervical cancer Medicaid. I know since I took over the program in January, we hadn't had any that needed that navigation, and they were all breast. But there was 3 before the end of the fiscal year, because we do run on a fiscal year. So we're just restarting.
No indication that cancer rates are rising with cervical cancer from what you're seeing?
Not with what we're seeing. I know we are doing, like I said, the colposcopies have went up, and we're trying to look into, in the future, opening colposcopies back up to be completed here for our patients. But right now, for the most part, if I was telling them earlier, if I used all my money on colposcopies, I could probably use all my targets before half the year was over. We're mainly focusing a lot of ours on the breast, because if I used it all on that, and the low-cost clinic in Cabarrus is really helpful, because our colposcopies are $50 there, and the LEAP procedures are $150 for our patients. I had an actual BSEP patient that was going for a colposcopy, and there was a miscommunication with Union OB, and that patient was billed $700. Or we get billed the Medicaid rate. So a lot of it is, there's a little bit of patient side to my work and a lot of case management and education about how we can get things funded and best take care of our patients.
The only other question I had was on the non-citizen
Yes.
coverage. How much, what percentage is that?
So, a lot of our VSEP patients are non-citizens. I don't have an exact percentage for you, I can get those numbers for y'all if y'all want those. But the breast and cervical cancer Medicaid, it really breaks my heart when we do have those patients that, so we can screen them, we can get them to the point of diagnosis, but then the service that they would need for breast and cervical cancer Medicaid, they don't qualify because they're not a citizen. And those are the patients that really fall through the crack, and we have to try to get charitable care through the hospital and any services we can for them. But it just kind of stinks that we can screen them, tell them they have cancer, and then if they're not a citizen, they can't have the Medicaid services, which
Is illegal non-citizen or just illegal?
Just not a citizen.
just not a citizen.
We don't differentiate
Yeah,
whether they're.
we don't discern that.
We don't discern their legal status.
I mean, I would think it would be important if taxpayers are paying for it.
This is state, so this
It's
is all.
state and federal
this is state
covered.
policy, like, we don't even have our own local policies here, this is all state program.
But if you have paperwork to be legal, you can get Beacon help, so. There's a need to, like,
We just follow the state manual.
get that.
Thank you.
Thank you.
The last on our division report, we can review information on the environmental health division, the recommendations.
Good evening. I have 5 environmental health fees to review with you this evening. The first one is for a certified food protection manager proctor exam fee. We provide the class. Well, we provided it twice this past year. We're going to look to provide it again in the fall. The fee that we have is for the full class. Now, more companies are offering online training, so we found the need to provide just a proctored exam service for these folks. So we want to add a $50 fee for that. That really can help a lot of folks that are busy, working in their facilities. Having that certified protection manager training is required, so just gives us a little more flexibility. The next 4 fees are related to the on-site water protection program and are the state's move toward private option permitting. So all of these fees are being required by Session Law 2023-90. The first 2 are associated with submittals that environmental health will receive from either a licensed soil scientist or authorized on-site wastewater evaluator or project engineer. They submit these private option permit packets to us, and we conduct a completeness review. And then environmental health does have some responsibilities with permitting and issuing an operations permit on the back end. So that first fee is for an improvement permit for that. The second fee is for a construction authorization permit. We will have situations where we may possibly do both. So those fees limit our ability to charge to 40% of our current fees that are in place. So in other words, 40% of the fee that we would charge if we did all that work. The soil and site evaluation, the design, the permit issuance, and all that. The next 2 fees, the first one is for an engineered option permit. That is fully a private option permit. Environmental health no longer does a completeness review. That is just a handling administratively of the submittal, filing, processing, and that kind of thing. And we communicate to building code enforcement or other municipalities as far as whether or not the permit has been issued. And that fee now is being limited to $35. We also have some oversight with those types of systems if they require maintenance and operation inspections. Same way with the next fee, which is just another category of private permitting option. It's called AOWE, Authorized On-Site Wastewater Evaluator. That's a new certification that was developed by the state. There's training that's in place now, so someone that is already a licensed soil scientist can also become certified as an AOWE, and they can pursue this permitting route. And again, that fee likewise to the EOP is $35. So unfortunately, we don't have a quorum this evening, but I wanted to present those fees to you. They are required by general statute to go into place September 1st. We didn't have a lot of time to get this worked up, but I appreciate your time this evening. If anybody has any questions, happy to answer them. Thank you.
Does anyone have a question? I think that concludes our division report. But we can move into any announcements.
One thing, business operations, we do have our senior systems support.
In business operations, we do have a vacancy that recently our senior systems support person is moving to Public Works. So that is a vacancy that's posted. So if anybody knows anyone that might be interested, we're definitely looking for someone in our IT world.
All right, and community support and outreach, we are working on our community health improvement plan, which comes from our community health assessment. Next month, I'm going to present on our health assessment, so you have more information about that. And we're fully, oh, I shouldn't even say we're fully staffed. I might jinx myself.
I just had one thing I was going to mention. Just recently, July 1st, we opened up our private drinking water well rehab and repair program. It's a grant program using ARPA funds. So I just wanted to let you know we've updated that program and extended the application period to the end of August. And I brought some updated flyers if you guys want one, but it's an exciting program. We really have received, I think, maybe 20 applications so far. We are still in the process of the request for bid process, trying to get a contractor selected, but we're optimistic.
Thank you. Just have two things. We didn't meet on July 10th. Most of you didn't. However, for 3 members, we had a potentially dangerous dog declaration appeal hearing. So I want to thank Meg, and Missy for assisting in that process. In the end, the person decided not to continue the appeal. So that ended up getting worked out, but I appreciate the time and energy for assisting in that process. The other thing I wanted to share is that many folks know Michelle McGrath on our staff. She's our nursing director. She has recently accepted a position in New Hanover County and is going to be leading us at the end of this month. Big loss for us, big gain for New Hanover County. I want to thank Michelle for the fine work and leadership that she's provided to all of us here in Union County.
I echo that, Michelle. And there's still time for you to change your mind, although I'm excited for you. But you are going to need this immensely. Also, I think you all are aware, but just want to offer our condolences for Stoney Rushing's family. Chairman of the Board of County Commissioners passed away this last week. His services were today, and And so obviously that is a very sad and big loss for Union County. So I just want to, again, offer condolences for his family and wanted to make sure that you all are aware of that. Also, because we didn't meet in June, wanted to let you know that the board did approve the FY24 budget. So we kicked off the new fiscal year July 1, and there were some reductions taken. The county manager had to take reductions across the board, I think, for most departments to cover some important needs and be able to maintain a flat tax rate. And Human Services did have about $532,000 removed from our budgets as a part of that. However, there were some very important things that they being the management team and the Board of Commissioners, were able to accomplish for our different divisions, and that includes the addition of a couple of not new positions largely, but positions that were previously funded by either whole or in part by ARPA or other one-time funds that had come about in the last few years. We still have several positions that are in that scenario, and we're going to be working to address those over the course of the next couple of years. But Public Health had one position and that was fully funded, that now is fully funded with county funds, and Community Support and Outreach had one that was partially 50% funded, and Transportation had previously had a conversion of 8 part-time drivers to 4 full-time drivers, and they were, I think it was 76, some large percentage funded by non-county funds. And so we've had increases in anticipated revenue for all of those areas, and we're able to utilize that increased revenue to cover the county costs associated with those positions. And in addition to that, we did receive 12 net new FTE positions, and those are in social services for Medicaid expansion. And speaking of Medicaid expansion, that is tentatively slated to go live in North Carolina on October the 1st. However, that is dependent upon the budget for the state being passed by September the 1st. And the information that we have presently is that that is not at all likely to happen. So assuming that that does not happen, there's still a very small chance that there would be some sort of special action taken in association with Medicaid expansion, but I don't think really expect that to be the case. And so if the state budget is not passed by September 1st, then the expansion work would likely be shifted to either December or January, one of those two, and they will make that decision by, I assume, October, so that we can know. But we do have a couple of positions posted because the state did advance funding because they know that we have to ramp up and be staffed to be able to go live when go live happens. And so we are actively recruiting for supervisor and 11 other positions that will be determining eligibility in association with expansion. So as Ashley always says, she's recruiting. So if you know anybody, send them your way. Yes, sir, Mr. Ford.
Janet, I was just asking a question. Where are you going to put those staff members? Where are they going to sit? Or not
Mr. Ford, that's a trick question. We have actually, amazingly, worked out the seating, and I think we'll be literally at complete capacity at that point, or maybe have 3 or 4 seats left in the building, but we've worked out seating, so we will have space for the staff. It required multiple different shifts of groups, but we also are going to, at this juncture, be able to keep the teams together. So that is a very good question, though, because should the county continue to grow, and the odds are very good that it will, space is going to be an opportunity that we will have to be able to try to tackle and resolve in terms of where people sit. The good news is we have lots of capability to work, and we have handy dandy devices for pretty much all positions now that can work from lots of different locations, so we do have flexibility. But, good question there. I think with the budget, that's pretty much all that is pressing related to human services. I do want to just mention and say that I think county management and the board have worked to demonstrate that they value employees year after year, and this year's budget also is representative of that. They did include, from an employee compensation perspective, a merit increase, and they're also in the process of completing a classification and compensation study that will look at job classification levels and associated pay bands. And there's some funding that is allocated in this year's budget to, should the Board of Commissioners, should there be recommendations to make adjustments upward to any positions, and should the Board of Commissioners choose to adopt those recommendations, there's some funding in the budget to be able to enable that for a portion of the year. And so that's something that we'll have additional information about in the fall in terms of what potential recommendations might be, and can bring that back around to you. And then in addition to that, I want to give a shout out to Jackie. Human Services was able to host Career and Technical Education Accelerator Camp event, which is basically Career Day, on July 26th with Union County Public School middle school students that are interested potentially in careers in health and health sciences. And so we had representatives from numerous different programs from CSO, environmental health, and our public health divisions. And I don't know exactly how many students, but we'll say 25 or so. And they had an excellent time, I think, anyway, and hopefully we sparked a little bit of interest. But Jackie, really appreciate your efforts in leading that, because, you know, not only does that hopefully broaden their horizons for kids. I mean, I know I didn't really have things like that when I was in school that would make you aware of an epidemiologist career or an environmental health specialist career. And there were some very interesting stories that our staff had to tell. In fact, it made me want to have like career day just for us to think, wow, some of the work that is done is pretty interesting. And the day-to-day aspects of it, I mean, you know, you get to hear about the summary results, but the day-to-day engagements, I think it really definitely sparked interest in a lot of those kids. And hopefully in a few years, they'll come back and apply to work with us. So, Jackie, thank you for that. And then the last thing I want to just mention is our opioid work group. So the opioid settlement funding, Michelle Lancaster is still working with us in association with that. And the Board of County Commissioners did adopt the initial funding recommendations that were made for 5 different partner agencies: Bridge to Recovery, Cameron's House of Hope, New Beginnings Treatment and Recovery Center, Ground 40, and then a treatment court, a new treatment court for the court system. And we have a core evaluation team that is inclusive of Stephanie Starr and Dennis, Kyle, who is our epidemiologist, Michelle Lancaster and myself, as well as Shanta Dubé from Wingate, and Wingate also received some of the funding. They're going to be heading up the analysis, data collection, and actually facilitating the work groups that will be ongoing. And we anticipate having quarterly meetings to try to, from a community partner level, not just with those entities, but with all of the other entities that play a role in substance use, specifically opioids, to be able to convene and discuss what's going on so that we can hopefully begin to make a dent in that world, because there are a lot of negative consequences and lives that are impacted, and a lot of it has to do with education, a lot of it has to do with resources, and so hopefully we'll be able to, again, begin to make a difference there. And I think that is all.
Anything else?
All right, the committee that volunteered to interview, either Carla or myself will be in touch. Thank you all for being here, and we'll see you again in September.